Mike Gibson, Vijay Kunadian, and we're coming to you live from ESC 2024, and we're talking about the senior RITA trial looking at an invasive strategy versus conservative strategy in those people over 75 with non-STEMI. Vijay, talk to us a little bit about why you did the study, what you did, and what you found.
The reason why we did this study was that in my clinical training, I've been in the same place. So when I became a consultant and I saw a big difference in the demographics, we were seeing more and more older people coming into the cath labs. But of course, not all older people are same. They're very heterogeneous. They have other conditions like frailty, cognitive impairment, multiple long-term conditions. So 85-year-old might look like a 65-year-old, but a 75-year-old might look like a 95-year-old. And all of these people, they were coming to the cath lab. And one day in my cath lab list, I think in the ACS list, I had about 10 patients. And pretty much 8 of them were born in the 1930s. And they had different demographics. Some were very robust, and some are wondering why they even came to the cath lab. And that's what I started thinking. And I went back to have a look at the evidence. There was absolutely no clinical trial looking at older people with MI in general and specifically non-ST elevation MI. So that's the reason, of course, having taken up an academic job and the university asked me, Vijay, what is it that you want to research on? And I said, well, coronary artery disease, acute coronary syndrome is my area of expertise, but it looks like we have a lot of older people that we are treating, and the evidence is hardly there. And they kind of encouraged me, yes, this is one of our expertise, area of focus, and the encouragement. And that's how it all started. So I put in for an initial grant, small grant, to do an observational study to collect pilot data. And then it went on to the senior RITA trial that we're talking about at the ESC Congress this year.
So talk to us a little bit about the design. How many patients? What were they randomized to?
So we recruited 1,518 participants from around 48 hospitals, 48 National Health Trust across England and Scotland. We opened 52, but 48 sites contributed patients. And we went to recruit these patients in an emergency department, medical admissions unit, cardiology ward, geriatric ward, because these are the areas where these patients present. And prior to that, well, our NICAR database said that as people grow older, the basic pharmacotherapy or invasive strategy, including angiography intervention, are underutilized in these patients. So we really went looking for these patients, including both PCI center and non-PCI centers. And we randomized them into conservative strategy, which is medical therapy only, which is guideline recommended secondary preventive therapy, management of diabetes, hypertension according to guidelines. And then the second group was the invasive strategy group, where patients underwent coronary angiography with a view to revascularization, either via PCI or coronary artery bypass surgery, plus guideline recommended medical therapy. And all of these patients, the unique thing was that we measured the frailty scores, cognitive function, and multiple long-term conditions using the Charlson Index and many other parameters that have not been measured, particularly in the ACS population before. And then we followed these patients up for the last visit was 1 year. So we have a minimum follow-up of 1 year, maximum of 5 years, with a median follow-up of 4 years. And again, senior RITA has the longest follow-up to date. And prior studies, and if you combine all of the studies, the overall sample size is around 1,480. They were all very small. They started off and massive challenges with recruitment, because I can tell you the challenges because it has taken us so many years. No wonder they didn't manage, but the largest sample size we have is around 470 patients from the After 80 study.
And what did you find?
So we followed these patients up. Our primary outcome was composite of cardiovascular mortality on non-fatal myocardial infarction. We also evaluated the components of the primary outcome, which is cardiovascular mortality, non-fatal MI, as well as many other elements that are relevant to this population, including bleeding, stroke. So the results in terms of the primary outcome, which is the composite of cardiovascular mortality plus non-fatal MI over a median of 4.1 years, we did not see a difference between the conservative group and the invasive group. But we did see a reduction in the occurrence of non-fatal myocardial infarction with a relative risk of about 25% in patients who underwent invasive strategy when compared to the conservative strategy. And there was also significant reduction in patients undergoing repeat revascularization procedure in the invasive arm compared to the conservative one. But the key thing is that when we look at older people and people say, why do you not do procedures in these people? Because they're afraid of procedural complications and bleeding complications. So we measured that very carefully around the time of procedure as well as during follow-up. And we found that the interventional procedure was safe in this population with the overall complication rate of less than 1%. That includes bleeding.
So what do you take away, Vijay? I mean, well, let me also ask you, how much crossover was there between the conservative arm and the invasive arm? I mean, if someone had horrible left main disease, did they get medical therapy or did they cross over to CABG? Kind of crossover rates.
So we're undertaking a big angiographic analysis, and that's not complete yet, but in the invasive arm, 90% of patients underwent angiography, and 10% didn't have angiography because of a number of reasons, because of clinical deterioration, or they passed away, or they ended up in the cath lab and the operator felt this patient is too frail, I'm not going to subject them to invasive procedure. In the conservative arm, around 5.6% of patients underwent angiography in the first week. And we allowed that in the protocol. So if there was clinical deterioration, they were given medications, and still they're having ongoing pain with ECG changes, they were allowed to have coronary angiography procedure. But I expected around 20% of patients in the conservative arm. But, you know, the operators, colleagues across the country really did adhere to the randomized strategy, didn't look after the patient really well. And in the end, we had 5.6% had in the conservative arm angiography within the first week after randomization.
So what's the clinical take-home message? You can reduce recurrent MI, you can reduce the need for revasc down the road. I heard you say there's very high mortality rates that wasn't affected. So what would you tell clinicians?
I think overall the message is that invasive procedure in older people are safe, and that's one thing that very clearly we've shown in our study. And people get older and they die due to a number of reasons, and many studies looking at older people do not demonstrate reduction in mortality. But what we have clearly shown is that we're able to reduce recurrent myocardial infarction, non-fatal myocardial infarction in particular, and reduce the repeat procedures in these patients. And I think as interventionists, that is a really important message for us. And also, when we are talking to the patients, we are able to make an informed decision as well as to individualize and tailor the therapy to these patients.
Great. Well, Vijay, congratulations. I'm very, very proud of you, having been your mentor for a few years. I knew you would do great things, and you have. And thanks for joining us, and thanks to all of you for joining us here live from ESC 2024.
Thank you so much, Mike. You've always been my inspiration, and you continue to do so. Everything I have learned comes from you, so I'm very grateful for all your support all these years.
Well, thank you, Vijay. You've done an amazing job. Thanks.